All right, future surgeons, get ready for this, because today we are diving deep into bone healing and non-union.
Ooh, sounds intense.
It is, but also it's essential knowledge for acing those postgraduate exit exams,
Hmm.
whether it's the FRCS or something similar.
Right, those exam.
Exactly. To make sure we really nail it down, we're using the Ortho Made Simple notes from mokyingren.sg. These notes were created by Dr. Mokyingren, a sports surgeon at National University Hospital in Singapore.
Oh, wow.
He aced his FRCS back in 2022, so we're in good hands.
Definitely sounds like it.
So are you ready to get into it?
Absolutely, I'm all ears.
Okay, great. Now, bone healing, it can seem simple on the surface, but it gets complex really fast.
You're telling me.
So to start, let's talk about Perrin's strain theory. It's a fundamental concept.
I've definitely heard of that.
Yeah, it basically explains how the amount of strain on that fracture site impacts the healing process.
Right, exactly. It's all about how much stability the fracture actually needs to heal the right way. Think of it like this.
Okay, I'm listening.
Too much strain, the bone fragments, they move around too much to even join up.
Makes sense.
But too little strain and the
Mhm.
cells don't get that kick. They need to actually go and build new bone, you know?
So it's all about finding that perfect balance.
That's sweet spot, exactly.
like the Goldilocks zone of stability.
Yes, precisely. And Perrin, he actually identified specific thresholds, different pathways.
Oh, interesting.
Yeah. So if that strain is less than 2%, you get what's called primary bone healing. So that's a direct process, no callus formation or anything like that.
Oh,
And then between 2% and 10%, you see secondary bone healing. This one involves callus formation, so it takes a bit longer. But if you go above 10%, you're in non-union territory. That's where things get complicated.
wow. So even a tiny difference in strain can totally change the healing outcome.
Oh, for sure.
That's incredible. Now let's get into those healing pathways a little deeper.
Okay, sounds good.
You mentioned that primary bone healing, it's direct, no callus formation. What does that even look like microscopically?
Okay, so picture this. Tiny cutting cones.
Cutting cones.
Yeah, they're these little guys that burrow through the fracture site.
What?
Yeah, and these cones are made up of specialized cells that break down that old bone at the front, and then they lay down fresh new bone at the back.
It's like a construction crew.
It is a perfectly coordinated one at that.
I love that visual. It's amazing what the body does.
It is pretty remarkable.
So what about secondary bone healing?
Ah, yes. Secondary bone healing, that's what happens when you have a fracture with a bigger gap, or maybe it's a bit unstable.
Right, AC.
It's a four-stage process. First, you've got inflammation. It's the body's natural response to injury, right?
Yeah, makes sense.
Then you get soft callus formation.
So is that like a bridge?
Kinda. It's like a cartilaginous scaffolding that forms to bridge the gap.
Yeah.
Eventually, that transforms into hard callus, which is much more bony, provides stability. And then finally, over time, that callus is remodeled into mature bone, like the original structure.
It's a whole process. Now, maybe this is a picky question, but why do we need two types of bone formation? Like why intramembranous and endochondral? Why both?
That's a really good question. It's about the different needs of the healing process. So think of intramembranous ossification like building a house straight on the ground.
Right.
It's quick, it's efficient, and you need that right at the edges of that fracture to stabilize everything early on.
Makes sense.
Now, endochondral ossification, that's like building a bridge.
Ah, okay.
You need that cartilage template first to bridge the gap. Then, slowly, it's replaced by bone.
So one's fast, one's for the long haul.
Yeah, you could say that. Slower process, but ultimately stronger, especially those larger gaps.
I love that. Now, we've got to talk about the factors that influence bone healing success.
Oh, yeah, there are a lot of those.
That's where Giannoutis' diamond concept comes in.
The diamond.
It's this framework that highlights everything you need for, like, a thriving bioreactor of bone healing.
I like that, the bioreactor. It perfectly captures the essence of Giannoutis' concept.
Right. So he breaks it down into four essential factors. First, we've got those osteoinductive factors.
Right, those are crucial.
They're like the signaling molecules. Like they recruit and activate those bone-forming cells.
Yeah, think of them like the foreman on a construction site.
Oh, I see.
They're telling the workers where to go, what to do, and those BMPs, those growth factors, they're like the big bosses.
So BMPs are calling the shots.
Exactly. They're giving the orders. Now, what about the workforce itself? Those are your osteogenic factors. These are the cells that can actually become bone-building osteoblasts.
Okay, so that's where bone grafts come in.
You got it. They provide a source of those vital cells. Those are the skilled laborers laying those bricks, building that structure.
So we've got the bosses and the workers.
What else do we need?
We need the materials.
Exactly. That's our osteoconductive matrix. It's the framework, the scaffold for that new bone to grow on, like the foundation and the building materials. And this can come from the patient or from a bone graft.
Makes sense. And we can't forget about a safe working environment, right?
Absolutely not. Mechanical stability, that's the fourth element.
That's a big one.
Huge. And honestly, it's probably the most crucial in the whole concept.
Seriously?
Yeah, because if that fracture site is unstable, all the signaling, cells, and scaffolding in the world won't make it heal. Like, you can't build a house on shifting sand, right?
It just won't work. So it's not just about biology.
No.
It's biomechanics, too.
Totally. We need that rock-solid foundation for everything else to come together. And remember, it's not just the diamond itself.
Oh, right.
We have to think about the host factors like age, any health conditions, even things like smoking. These can all impact how well the body heals.
It's really a holistic view of healing. We need all the pieces working together for it to work. Now, before we jump into non-unions, there's a newer theory that I find so interesting.
Okay, what's that?
The unified bone healing theory. It feels like a more dynamic approach to the whole process. What's the idea behind it?
So it proposes that the whole healing tissue around that fracture should be seen as one big interconnected unit. It's called the bone healing unit, or BHU.
The BHU, okay. So instead of focusing on the individual parts, we're looking at the whole thing.
You got it. Big picture thinking.
I like it.
And the cool thing is, this BHU, it responds dynamically to the forces on it. It adapts, it remodels. And this theory even brings in things like para and strain theory, Wolff's Law, the mechanostat.
Wow. It ties everything together.
It does. It explains how the bone senses and responds to being loaded, the mechanics of it all.
So it's not just about having stability.
Right.
It's about the right kind of stability.
You need that stimulation to promote that optimal healing. It's fascinating stuff, really.
It is. And I think understanding this is going to be so important when we talk about non-unions.
Oh, absolutely.
Those are the cases that can really throw you for a loop.
Yeah, those are tough.
So stay tuned, because next we're going to break down those tricky cases and explore how to use this knowledge to get those bones back on track. And don't forget, this deep dive is all thanks to the excellent Ortho Made Simple notes from mokyingren.sg.
They're a great resource.
Seriously, for anyone prepping for those exams, you need to check those out.
Couldn't agree more. Welcome back, everyone. Now that we've got those bone healing principles down, let's talk about non-unions.
Ooh, non-unions. Those are tricky.
They can be. It's those cases where the fracture just doesn't want to heal, right?
Yeah, I remember feeling a bit overwhelmed by them during residency.
Oh, I bet.
It's like you do the surgery perfectly, but the bone just isn't playing along.
It can be frustrating, for sure.
So how do we even define a non-union? What are we looking for?
Well, there's this definition from the FDA back in 1988, but it's still widely used.
Okay.
Basically, it's when a fracture shows no sign of healing for 3 months straight, or it just hasn't healed after 9 months.
So it's about time, but also about lack of progress.
Exactly. And clinically, you'll see things like pain that won't go away, instability at the fracture site, and of course, those x-rays will show that it's not bridging.
Yeah, the x-rays are key. But how do we know if it's just taking its sweet time, or if it's really heading for non-union territory?
That's a good question. On those x-rays, you want to look for a few key things, like a persistent gap in the fracture, no callus formation, or maybe the callus is there, but it's not well defined. And sometimes you even see bone resorption around the fracture ends.
Oh, wow.
Yeah, and that suggests the bone's trying to remodel, but it just can't bridge that gap.
I guess trying its best, but it's just not working.
Right. And those are the signs that should make you think, this could be trouble.
Definitely red flags.
Huh.
Now, we know non-unions, they're not all the same. Right?
Oh, absolutely not. You've got different types, and understanding those differences is crucial for treatment.
Okay, so break it down for us. What are the different types?
Well, the first big difference is between infected and aseptic non-unions.
Okay, that makes sense.
Infected ones, as the name suggests, involve an infection right at the fracture site.
Oh, yeah.
Yeah, and that throws a wrench in the whole healing process. You have to be aggressive with treatment, debridement, antibiotics, sometimes even special implants.
So infection is a whole other beast.
It is. But for now, let's focus on those aseptic non-unions.
Okay, sounds good.
Now, even within those, you have different types. You've got hypertrophic and atrophic non-unions.
Those names always trip me up in med school.
I know, right?
Oh.
But understanding the difference is super important.
So what's a good way to remember, and more importantly, what do they actually mean for non-unions?
Okay, think of hypertrophic non-unions like that student who tries really hard but just can't seem to get the right answer.
Okay, I can picture that.
They've got tons of callus formation, which means the healing process is active. It's like the body's saying, hey, I'm trying here, but something's stopping it from bridging properly.
So it's not a lack of effort.
Nope, it's a stability issue.
So what kind of situations would cause that?
It often means the fracture site just isn't stable enough. Could be the initial fixation wasn't good enough, or the implant failed, or even just poor bone quality.
So even if the bone wants to heal, it can't if it's not stable enough.
Right. It's like trying to build a bridge on shaky ground.
That's a great analogy. Now, what about those atrophic non-unions? Those sound a bit more concerning.
They can be. They're like that student who's just given up.
Oh, no.
Yeah, they have very little callus formation, which means there's not much biological activity going on.
Like the body's just throwing in the towel.
Pretty much. It said, nope, I'm done with this.
Wow. What would cause that to happen?
A few things. Poor blood supply to the fracture site is a big one. Like if there's severe soft tissue damage or if the patient has vascular disease.
So the nutrients and oxygen just can't get there.
Exactly. And then even if an infection has been treated, it can leave scar tissue behind, and that messes up the healing environment.
So even if the bone wants to heal, it might not have what it needs.
Exactly. Now, this difference between hypertrophic and atrophic, it's really important for how we treat them.
Okay, I can see that.
So when we see a non-union, first thing is to figure out which type it is. Hypertrophic ones, they often respond well if you fix the mechanical problems.
So give that hardworking student the support they need.
Right. That might mean revising the fixation, adding a bone graft for stability, or even using special implants designed for non-unions.
So what about the student who's given up? How do we deal with atrophic non-unions?
Those are tougher. You need to bring that healing environment back to life.
Oh, okay. How do we do that?
It usually means a combination of things, maybe treating any underlying medical conditions, improving blood supply to the area, and giving it a good biological boost.
Like jump-starting the process.
Yeah. Bone grafting is key here, and we often use grafts that are packed with those osteogenic and osteoinductive factors.
So this is where Giotti's diamond concept comes back in.
Absolutely. Remember those 4 key elements: osteogenesis, osteoinduction, osteoconduction, and stability. We need to optimize all of those to create that perfect healing environment.
Like we're setting up the perfect construction site.
Exactly. Giving those bone-building cells everything they need to thrive. Now, speaking of bone grafting, that's a topic that comes up all the time in exams, and it's essential for managing these non-unions. So let's dive into the different types of bone grafts and what makes them special.
Okay, I'm ready. Let's talk bone grafts.
Okay, so allografts, those grafts that come from donors, they seem like a pretty good alternative to autografts, especially if we need a lot of bone or want to avoid doing an iliac crest harvest.
Yeah, they can be a great option.
But how do we make sure these allografts are safe? What kind of processing do they go through?
It's a pretty intense process, actually. There are 2 main parts: aseptic processing and terminal sterilization.
Okay, so aseptic processing, what's that all about?
It's all about cleaning and prepping that bone, making sure it's as clean as possible.
So like getting it ready for surgery. Yeah, exactly. We use things like sonic waves, ethanol, antibiotics, and then we package it all up in sterile containers.
Wow, that's thorough.
It has to be. We want to remove anything that could cause problems later on.
Right, of course. So then terminal sterilization, what happens there?
That's the step that makes sure there are absolutely no microorganisms left on the graft, like bacteria or viruses. No chance of infection.
Okay, that's critical. And how do we do that?
Usually with radiation, like gamma radiation.
Gamma radiation. Sounds intense.
It is, but it's very effective and safe for the bone itself. It just completely neutralizes anything that might be lurking.
Wow, so the bone goes through all of that, and then how do we preserve it until we need it for surgery?
We have a few different methods, each with its own pros and cons. You've got fresh allografts. They're stored at 4 degrees Celsius for up to a week.
So they're the freshest option.
They are, but they also have the highest chance of triggering an immune response. But on the plus side, they retain those viable cells and growth factors.
So it's a trade-off. What if we need to store them longer?
Then we have fresh frozen allografts. They can be stored for much longer, and they're less likely to cause an immune reaction.
How long can those be stored?
They can last for a year at negative 20 degrees Celsius, or even up to 5 years at a negative 70.
Wow, that's pretty amazing.
It is, and they still have a good amount of those BMPs, those growth factors.
Okay, so fresh frozen is like the middle ground.
You could say that. And then we have freeze-dried allografts.
Freeze-dried, like those astronaut ice cream sandwiches.
Kind of. They're the least likely to cause any immune problems, but they don't have as much structural integrity and fewer BMPs.
Okay, but they last forever, right?
Pretty much, yeah. They have an indefinite shelf life.
So how do you choose which type of allograft to use?
It depends. What's the defect like? Where is it? How healthy is the patient? And what properties do we need from the graft?
So it's a judgment call.
It is. We have to weigh the pros and cons and choose the best option for each patient.
Right, that makes sense. Now let's talk about bone substitutes. Those are the synthetic materials that can act like natural bone, right?
That's right. They're like bone mimics.
What are some of the ones we use?
Calcium sulfate is one. It's absorbed really quickly by the body, so it's good for filling in small gaps. Then you've got calcium phosphate. It comes in different forms, and it can actually provide structural support.
So it acts like a scaffold for new bone to grow on.
Yeah, exactly. And it's gradually replaced by the body's own bone over time.
That's amazing. What about tricalcium phosphate?
That's another popular one, yeah. It's interesting because it actually changes into hydroxyapatite after it's implanted.
So it transforms inside the body.
It does. That means it provides that structural support, and it slowly resorbs over time.
So many different options to choose from. How do you decide which bone substitute to use?
Again, it depends on the situation. Do I need it to resorb quickly? Do I need it to provide support for a long time? It all factors in.
It's like choosing from a menu of building materials.
Yeah, you could say.
Well, this has been fascinating, really. We've covered so much ground today, from the basics of bone healing to those tricky non-unions and all those different bone grafting options.
It's a complex topic, but so important for orthopedic surgeons.
Absolutely. And I have to say, the Ortho Made Simple notes from mokyingren.sg have been such a helpful resource for this deep dive.
They really are a great resource for anyone studying for those exams.
So to all our listeners out there, remember, mastering bone healing and non-unions isn't just about memorizing facts. It's about understanding how it all works.
Yeah, you need to be able to look at an X-ray and see the bigger picture.
Exactly. And then you can use that knowledge to give your patients the best care possible.
Well said. And never stop learning. Orthopedics is constantly evolving, so stay curious.
That's great advice. All right, future surgeons, go out there and crush those exams, but remember, the real learning starts when you're in the OR, applying all of this knowledge.
Couldn't agree more.
Thanks for joining us on this deep dive into bone healing and non-union. It's been a pleasure.
Thanks for having me.